Hi, I'm Marcos Maldaun, founding president of SNOLA, the Society for Neuro-Oncology Latin America. And this is a great honor to have here Professor Roger Stupp. First, you are very welcome in Brazil. Thank you for coming. Thank you for sharing your huge experience in the neuro-oncology field. Dr. Stupp is a professor at Northwestern University in Chicago, and he's well known from everybody as one responsible for the landmark papers in neuro-oncology field. We'd like to discuss, Dr. Stupp, first about TTF, the tumor treating field. Can we consider TTF the new first-line standard of care treatment added to chemoradiation and temozolomide?
So first of all, thank you very much for having me. It's a great honor to be here, and it's a great pleasure, and congratulations to a very impressive meeting that you have set up. Tumor treating field is a new modality that has been studied over the last 10 years in several clinical trials. We studied both and more or less in parallel, both in recurrent disease and in newly diagnosed. We have shown in preclinical work that using alternating electrical fields, so-called tumor treating fields, that they can interfere with physical force during cell division. This has been shown in preclinical experiments, in animal experiments, and then we went into clinical application in patients with glioblastoma. While in the first randomized trial in recurrent disease, it did not show a significant improvement over standard salvage chemotherapy. It was not worse, but it was equally bad. As we know, we don't have very good second and third line treatments in brain tumors. We nevertheless saw some activity in a way we saw at least a few % patients that would actually respond. So that was intriguing. If you know from the prior work we have done that I've always been advocating that when you have a new technology, you want to bring it forward first line. You don't want to develop new treatments in recurrent disease. This is too heterogeneous, too far advanced. Patients don't live long enough that there's actually even a chance that the new treatment can show an efficacy. So we went on to go for a randomized phase 3 trial in patients with newly diagnosed glioblastoma who had just completed chemo and radiation therapy, were stable at that point, to receive maintenance temozolomide by itself or the maintenance temozolomide plus tumor treating fields. And in this trial, 695 patients were randomized, 2-to-1 randomization, so 466 patients had received tumor treating fields. In December of last year, we published the final analysis on the whole data set and have shown with a hazard ratio of 0.63 a statistically highly significant improvement in overall survival. And when we look a little closer at the data, we see a consistent prolongation of both progression-free survival and also overall survival. So that was the long answer to your question. So if you ask me, based on this, yes, I think they should be considered standard of care for newly diagnosed patients who fit the criteria we had in the trial. Interesting enough, so this comes about 10 years later after we established temozolomide. And the benefit we saw with temozolomide also was a hazard ratio of 0.63. So we got another improvement.
Excellent. And considering that this is a new device, should we have any concern regarding complications about this new technology? I mean, seizures, skin rashes, or other neurological deficits that this new device can cause to our patients?
So, as a physician, especially at the beginning, that what I was very also concerned, saying, do we see more seizures? What kind of complications can we get when we have that? And in both randomized trials, we did not see an increased incidence of seizures. Now, when I start explaining that or even highlighting this as that we haven't seen that, people who understand probably a little bit more about electrophysiology than myself are going to tell me, with the frequency used for tumor treating fields, this is not going to excite neurons, so there is no risk of seizure. So physicists being involved are not surprised at all, saying, of course, that doesn't do it. Excellent. The other side effect you mentioned is skin rash. It's not per se skin rash, but it's a skin reaction when you put electrodes on the patient's scalp. So yes, you get some skin reaction. Actually, in the majority of patients, you get some skin reaction. Overall, this is always mild, hardly ever needs discontinuation of treatment. Occasionally, you need interrupt treatment for a couple of days or so. It can be solved with local treatments. But that's the major limitation and side effect. It's local. As it is a local treatment, we don't have any of the systemic side effects we are used to when we treat with systemic treatments a tumor.
Excellent. And the final question regarding TTF. Now you are leaving the targeting era. Do you think TTF could be useful and could help any kind of patients regarding MGMT status, age, elderly patients, methylated or unmethylated patients? Is there any difference between the response about a TTF for these subgroups?
So we looked at the subgroup analysis, and I think consistent with the mechanism of action, we don't see a difference. With other words, we see a benefit with the addition of tumor treating fields in all subgroups, including elderly, interesting enough, including the ones who had a biopsy only, or the ones who had an unmethylated gene promoter. Now, the relative benefit is there. Some patients nevertheless do so poorly for other prognostic factors that you don't get that much of a benefit from it, but it's consistently seen in all the subgroups.
Excellent. So considering that we are adding a new strategy regarding oncogenes, trying to solve this serious problem that is a GBM, it's a terrible disease, a terrible tumor. Can we combine anything else? I would like to extend my question to immunotherapy and immunomodulation. Do you think, is there a rule for immunotherapy nowadays for GBMs, or it's too early? Can we see this magnificent results that we've been seeing for melanomas or lung cancer or other cancers that are supposed to be very difficult to control? Can you expect that this immunotherapy act and having good results for gliomas and especially GBMs?
Let me backtrack for a second. I think with the tumor treating fields, it's a new modality that can be combined with anything else we need to do. Because it has no overlapping toxicity. I think that's the great advantage, to have something to stay there which I can combine. I fully agree with you, we need to make further improvements. This is just one step further, but we're not there. So yes, precision medicine is there to understand its place, and immunotherapy, there's a lot of talk about immunotherapy. Now, so far, immunotherapy has not kept its promise in brain tumors to the same way as we have seen after 30 years of research in melanoma, where nothing worked, after many disappointments in lung cancer. So that doesn't mean it will not work, but not the strategy as simplistic as it is with just adding a checkpoint inhibitor. So we probably need combinations there. We may need a combination of checkpoint inhibitors or other modifiers. We may to have it combined a vaccination plus checkpoint inhibition. Viral therapy, replicating viruses, but likely also in combination. So that's where the field is going. That's what we at the Malnati Brain Tumor Institute in Chicago are doing, having trials, exploring that. But it's clearly too early to call it victory. And everything is promising as in early stage, but at the end we need to do rigorous trials, and sometimes we do not expect much and we see an effect. That was true for temozolomide, as is true for tumor treating fields. Sometimes we have high expectations like bevacizumab or high expectations like selengitide, and we have the big disappointments.
Okay, so finally, as a neurosurgeon, I must ask you, for our neurosurgery community, do you think extent of resection nowadays is an important concept and should be applied for all GBMs, or things are changing considering that we have new strategies with good results?
No, I think you will not be out of work. I think in all trials when we look, extent of resection has at least a prognostic implication. Of course, we will never be able to do a randomized trial where you compare or not compare. And nobody is going to leave a tumor in when you can easily take it out. How much you need to take risks, this remains an open question. So with colleagues in Switzerland, we are running a trial and hoping that others will join this effort where we look at the value of resection in recurrent disease, because that's another unclear question in that regard. So extent of resection, yes, will be important. It needs to be experienced surgeon, well done surgery, with all the tools that is available, in addition to the other treatments.
Excellent. So my final point and question to you, for many years, and a good friend of us is steroids. We always, any problem, any concern with, for our patients, we just raise the steroids income. Do you think, or should we avoid steroids nowadays as much as we can, considering all this immunomodulation for several clinical strategies that should be applied for these patients, or doesn't matter?
I thank you so much for that question. I should actually have almost have asked for that one. No, I think steroids is really one of the most toxic drugs we have. Not for the short course if you need it for a few days, but on the long run. And we have better ways to control inflammation. So yes, steroids, we have to be more careful. We probably don't always need the high doses we give. The 4 times 4 milligrams of dexamethasone a day comes out of laboratory studies from 1959 and 1960, never been reproduced. Actually, dexamethasone has a long half-life, so actually with a once daily administration you get the same effect. And I think when you have somebody who is steroid dependent because there's a lot of inflammation, here some low dose bevacizumab is actually a great drug. So bevacizumab will not prolong survival, but it will indirectly help to spare steroids. And I think as we go for immunotherapy at the same time, these kind of strategies, it doesn't make sense to give an immunosuppressive drug at the same time. So I very quickly will switch to something else if needed.
Excellent. So Dr. Stupp, I'd like to thank you again for sharing your huge experience with us. Thank you for coming over Latin America, especially Brazil and São Paulo, for this NOLA meeting. You are very welcome. Thank you so much.
It's my pleasure. Thanks for having me.